मॉर्निंग से वाली रास्ता हो अच्छा चलो मॉर्निंग को के आईटी वालों को फोन करना है नहीं नेट पे चल रहा है ये क्या कहते हैं हमारा सेमिनार में प्रोजेक्ट करने के लिए हाँ जो है ना
Good morning.
Can you hear me?
Good morning, everyone. I'm Vishali. I'm going to present the topic Bupropion. It is one of the most prescribed antidepressant in the United States, often used as an alternative to SSRI and SNRI in addition to depression. It is also FDA approved for smoking cessation, the only antidepressant to receive FDA approval for SAD, seasonal affective disorder. It is used for treatment for ADHD, sexual dysfunction, obesity, and fatigue. The major metabolite of bupropion, hydroxybupropion, is investigated as a potential antidepressant. It acts as a non-adrenergic agonist or dopamine reuptake inhibitor. Effects of bupropion on non-adrenergic activity appear more consistent than its dopamine effects. It reduces the 24-hour excretion of norepinephrine and its metabolites. Chronic administration of bupropion appears to modestly inhibit the tyrosine hydroxylase activity. It is not a significant inhibitor of serotonin uptake due to its lack of significant serotonergic effects. It is thought to be the major factor in bupropion's lack of sexual side effects and its general lack of efficacy in anxiety disorders. This absorption is not substantially affected by food or any anticholinergic administration. The peak blood level occurs within 2 hours of administration and it is tightly bound to protein. The mean half-life is about 21 hours. It undergoes extensive first-pass metabolism. Most elimination is fecal. It's one of the most major clinical use is in depressive disorders. It is an effective antidepressant. Bupropion have evolved out patients with mild to moderate depression. In children and adolescents, suggests benefit of bupropion in pediatric depression. In lower doses, it may be effective and well tolerated. No clear benefit of bupropion monotherapy has been seen, so it is given by combining with SSRIs, SNRIs, or mirtazapine. It is commonly used adjunctly with antidepressants to treat SSRI-induced sexual side effects, enhances libido, and it is more evident in women than men. It has been favored as an adjunctive treatment for bipolar depression too. Another important clinical use is smoking cessation. Due to its efficacy in nicotine withdrawal and cravings, it may mimic nicotinic effects on dopamine and norepinephrine, which may attenuate withdrawal symptoms. Twice as effective as placebo in reducing acute nicotine withdrawal symptoms, nicotine cravings, and maintaining abstinence. About 30% of patients are able to quit 1 to 3 months and about 1 to 5 times as likely to remain abstinent as placebo-treated patients. It also appears effective in COPD, cardiovascular illness, alcoholism, schizophrenia, and those with comorbid depression. The usual starting dose for smoking cessation is 150 mg per day with a target dose of 300 mg per day within 7 days. Responders may continue bupropion treatment chronically to prevent relapse. The another is obesity and eating disorders. The FDA approved the combination of obesity and eating disorders as 4 large registration trials were completed with BMI more than 27 to obese, BMI more than 30 patients. 3 weeks of dose titration was followed by 1 year of treatment. Subjects were given a combination of naltrexone and bupropion along with dietary modifications by lowering the calories per day. Patients lost about 5% more of total body weight versus subjects in the control group. The most side effects are some of them back off during the treatment, lead to discontinuation were nausea, headache, and vomiting. Some of the common side effects were also constipation, and the bupropion alone has also some mild anorexic effects that has been evaluated. Patient treated with bupropion tends to lose 1.1 to 4.5 kg at 6 to 12 months. Bupropion has also been investigated in the treatment of binge eating disorder. Some other clinical uses, in addition to this FDA-approved indications, has been clinically tested for a number of other conditions. Bupropion in adults with ADHD have been more consistently positive, including sexual dysfunction in non-depressed patients, fatigue in cancer patients, the treatment of amphetamine addiction, lowering tumor necrosis factor A, and improving concentration in patients with ADHD. It has some of the side effects, like insomnia is one of the most common side effects of bupropion. Anxiety and agitation may occur. It has an enhanced risk of seizure in patients with a history of eating disorders, head trauma, or previous seizure disorder. The other common side effects reported in trials including nausea, dry mouth, excessive sweating, tinnitus, and rash. The most common reasons patients discontinued bupropion in acute clinical trials in depression were nausea and rash. Bupropion has a favorable cardiovascular profile with very few cardiac effects, but investigation is still going on. Bupropion is commonly used in patients with known cardiac pathology. Other side effects such as hepatotoxicity, hematopoietic changes, and severe headaches occur rarely. Thus, the side effect profile makes bupropion an important alternative to many patients who cannot tolerate other antidepressants. Hydroxybupropion are metabolized via the cytochrome P2B6, so there is a risk of interaction between oncology agents and the muscle relaxants. Rare seizures that have occurred in combination of fluoxetine and bupropion. The concurrent administration with MAOIs is contradictory. Overdose of bupropion sometimes been associated with deaths. Cause of death in these overdoses have included complication of status epilepticus and arrhythmias. Tachycardia, intraventricular conduction delays, and QRS complex widening have also been seen. So the treatment for overdoses includes lavage, seizure treatment and prophylaxis, cardiac monitoring, and vital sign support. Bupropion hydrochloride is available in IR, SR, and 11 forms. The usual starting dose in 150 mg per day taken in the morning. Average therapeutic dose for the treatment of depression is 300 to 450 mg per day. Compliance to bupropion IR was somewhat difficult when dosed at 150 mg 3 times a day. Dose of the SR form was 150 to 200 mg twice a day. The 11 form could be taken all in one morning dose. More consistent blood levels and perhaps less sleep disruption. Thank you.
The references are
It's a CTP.
CTP. Is it written in CTP that bupropion is not effective as monotherapy? Effective as monotherapy.
It's not as effective as monotherapy, so it is given in combination with other exercise.
What is the reference for that? Will you pick that from? Which slide? Really given it. It's commonly used by GP. To say that no clear benefit of bupropion. Basically, reference is which indication, maybe for some specific indication they have said this, right? Say depression. Bipolar depression, patients with a history of bipolarity. So you start with bupropion because if there is a risk of patient developing not be initial bipolar. Coming to you with first episode depression. Bupropion is preferred because there is a risk that we switch.
And basically, this is Bupropion and stelling depression. Okay, cool.
What is the common side effect? You said common side effect.
Agitation, nausea, insomnia.
You got skipped. There is also disparate. Like if you've taken, see, clinical trials are done in a different settings, and then bupropion is very long. It is there in clinical settings for quite some time. Clinically, insomnia is one of the most leading cause for disruption. Also, it is you give 150 milligrams in the morning. As soon as you switch to 300 milligrams or you switch to 150 BD, the patient starts complaining of it very fast.
Good morning, everyone. Myself, Anshul Verma, and I am here to present my topic, that is calcium channel inhibitors. Firstly, we will talk about how calcium affects the psychiatric, how calcium is related to the psychiatric disorders. Intracellular calcium ions regulate the activity of neurotransmitter release like serotonin and dopamine, which are dysregulation of which results in psychiatric disorders like bipolar disorder. Moderate increase in free intracellular calcium ion concentration stimulates cellular activity, and if the same calcium ion concentration increases much more than the normal value, then the ions inhibit the same function. A hyperactive intracellular calcium ion signal contributes to the action of mania. The immediate source of increased calcium in bipolar disorder is increased release from the intracellular calcium stores, which is promoted by inositol triphosphate, a product of membrane phosphoinositide. The mediators which increase the release of stored calcium includes increased PI turnover, that is phosphoinositide turnover, hyperactive neuronal calcium sensor 1, hyperactive G protein, mitochondrial dysfunction, increased production of protein kinase C, and decreased expression of anti-apoptotic and neurotropic BCL2 gene. Now the classification of calcium channel inhibitors. CCBs are divided into 3 classes: phenylalkylamine, that includes verapamil; benzothiazepine, that includes diltiazem; and dihydropyridine, which are further divided into 3 generations. First generation include nifedipine, second generation include isradipine, nicardipine, and philodipine, and third generation includes amlodipine. Mechanism of action. In normal physiology, calcium ion enters the cytosol through receptor operated channels, which are gated by hormones and transmitters like catecholamines, voltage gated channels, which are also known as PDCs, potential dependent channels, which are gated by membrane potential, and stretch operated channels. Under physiological condition, all these 3 channels are interconnected. That is, PDCs are regulated by receptor mediated events, and receptor mediated events are can be mediated by voltage dependent events. In addition, extracellular calcium influx triggers the release of intracellular calcium ion from the calcium stores. Calcium channel inhibitors acts on the PDCs, that is potential dependent channels, and hence inhibits calcium influx. PDCs consist of 5 subunits, which are alpha 1, alpha 2, beta, gamma, and epsilon. Alpha 1 channel are the
alpha 1 subunits are the units on which most of the calcium channel binders acts on, and it has a hydrophobic region that spans the cell membrane and gets the actual calcium pore. The subunit have actually 4 and possibly 7 or more separate binding sites for different classes of calcium channel blockers. The potential dependent channels are further divided into 6 subtypes: L type, that is long lasting type; T type, that is transient type; N type, that is neither L type or no B type; and P type, Q type, and R type. The L type or the long lasting type channels require significant depolarization for calcium entry and inactivate slowly. These channels don't participate directly into neurotransmitter release, but they play an important role in determining neuronal excitability. Most of the currently available calcium channel blockers bind to the L channels, which are primarily located in cardiovascular, endocrine, nervous, and nervous system and muscles. The variation in different calcium channel in structure of different calcium channel blockers produce variation in their potency at different L channels in different tissue of the body. As you can see, verapamil binds to the alpha 1 subunit of L channels, resulting in inhibition of the calcium influx into the cytosol, and hence also inhibits the release of intracellular calcium ions from the calcium stores. Now, the indications of calcium channel blockers are these have calcium channel blockers have the capacity to reduce cellular hyperactivity without suppressing the normal activity. So they are used to treat angina, hypertension, migraine, headaches, Raynaud's phenomena, esophageal spasm, premature labor, and epilepsy. Calcium channel blockers have found to retard atherosclerosis and also have the potential to reduce anoxic brain damage, which is the main pathology in Alzheimer's disease. So researches are being done to use this feature to slow down the progression of Alzheimer's disease. In few reported cases, when verapamil and diltiazem were administered to brain damage maniac cases, the CCBs were well tolerated. CCBs might be considered in presence of physical condition in which the other medications are more dangerous, like in pregnant maniac patients. Some studies on small levels are done in which a study of 28 pregnant women with acute episodes of mania or bipolar depression when given verapamil are found with no complication of pregnancy, as well as 100% response to mania, 77% response rate in mixed state, and 39% response rate in depression is documented. Calcium channel blocker pharmacokinetics. The CCBs are taken orally, and the bioavailability of verapamil and diltiazem is around 10 to 35%, 41 to 67%. The most of the calcium channel blockers have a half-life of around 2 to 6 hours, and with the exception of amlodipine, which have a half-life of 30 to 50 hours. Administration in psychiatric disorder, verapamil in treatment of mania, daily required dose is 240 to 480 mg per day, with a frequency of 3 to 4 times a day, because it have a short half-life, 4 to 5 hours. Nimodipine doses for bipolar illness have ranged from 360 to 720 mg per day, which is much more than the FDA approved maximum dose of nimodipine, but there are no side effects with increased dose of nimodipine. The frequency of nimodipine is 4 to 6 times a day. Amlodipine is the only CCB that is effective when it is administered once daily with a dose of 4 to 15 mg per day. However, there is little experience with this medication in mood disorders. Side effects: calcium channels produce vasodilatation, so the side effects includes dizziness, headaches, lightheadedness, skin flushing, tachycardia. Other side effects are constipation, somnolence, shortness of breath, and wheezing. Parkinsonism and delirium have occasionally been associated with use of CCBs, probably because of inhibition of postsynaptic dopamine channels receptors. Peripheral edema due to precapillary dilatation with reflex postcapillary constriction is seen. Verapamil and diltiazem produce sinus bradycardia, and hence can aggravate heart failure. Thank you.
Good morning. I, Anshu Kumar, going to present the topic buspirone. Buspirone is an azaspira decanedione derivative synthesized in 1968 in the laboratories. It has been studied for its potential antidepressant and anxiolytic effect, though developed as an antipsychotic drug. Mode of action, it acts on two receptors, serotonin 5-HT and dopamine. It has high affinity for 5-HT1A serotonin receptor acting as agonist and partial agonist, and moderate affinity for D2 dopamine receptor acting as both agonist and antagonist. It does not have strong sedative effect as well as no potential for dependence. As we can see, buspirone, unlike other anxiolytic like benzodiazepine, do not interact on GABA receptors. It only acts on 5-HT1A receptors. And in the presynaptically, it is full agonist, and postsynaptically, it is partial agonist. Low doses of buspirone selectively activate 5-HT1A autoreceptor to increase the 5-HT1A heteroreceptor expression in the nucleus accumbens and counteract effects of MPD, and downregulation of 5-HT1A heteroreceptor in the nucleus accumbens of MPD treated animals decreases excitatory glutamine input to ventral tegmental area dopaminergic neurons to elicit drug warning and reinforcement. Pharmacokinetics, it undergoes extensive first-pass metabolism when ingested orally with bioavailability of 4%. Bioavailability is affected by food. The remaining drug enters systemic circulation along with its major active metabolite, that is 6-hydroxybuspirone and 1-pyrimidinylpiperazine, all readily crossing the blood-brain barrier. 86 to 95% of the drug is bound to the plasma protein, and it is metabolized by through oxidation by cytochrome P453A, which is the most abundant polymorphic and wide inter-individual variation, due to which the T half-life is around 3 to 11 hours and vary according to the people. The uses of the buspirone are the generalized anxiety disorder, other anxiety disorders like panic disorders, OCD, PTSD, major depressive disorder, alcohol and cannabis dependence, and smoking cessation. Effects on organs and systems. Nervous system. The areas reported are dizziness, headache, drowsiness, fatigue, lightheadedness, insomnia, decreased concentration, abnormal thinking, excitement, depression, vivid dreams, and hostility. Gastrointestinal systems include nausea, GI distress, diarrhea, and vomiting. Cardiovascular systems, palpitation and tachycardia are the most common listed areas. Syncope, hypotension, and hypertension can also occur. Other rashes, change in libido, change in weight, and menstrual irregularities. Precaution and contraindication. It should be avoided in patients with hypersensitivity to buspirone. Patients with liver and kidney diseases should receive less than the recommended dose and should be avoided in severe impairment. Lack of teratogenic, carcinogenic, and fetal impairment effect of drug is seen in vivo animal studies. Drug interaction. Buspirone with MAO inhibitors lead to increase in blood pressure. Verapamil, erythromycin, and grapefruit juice increases the area under the curve and Cmax of buspirone, whereas rifampin decreases it. Co-administration of both haloperidol and buspirone in patients with schizophrenia increase the plasma concentration of both. Buspirone clinical trials are for agitation, psychosis, somatic dysfunction, including fibromyalgia, sexual dysfunction, premenstrual syndrome, sleep apnea, attention deficit, hyperactivity disorder, withdrawal from other medication, or substance abuse.
Calcium channel blockers. Can you name any calcium channel blocker that is using migraine? Is it one of the indications? These not all calcium channel blockers are. How does it actually act? The calcium channel blocker give a number of indications. What does it do? Actual action कहाँ पे होता है? ठीक है, क्या होता है? Muscles में करता है ना? Basically, actions to habit flexes. That's the main how acts. That is why all the indications that you see, they are causing muscle relaxation. What are the side effects? Yes. Angioedema, swelling of knees, joint. Yeah. So that is. And Buspirone, how does it act?
So it acts on serotonergic and dopaminergic
What is it? Agonist, antagonist?
So on 5-HT1A presynaptically it is agonist and postsynaptically it is partially agonist, whereas in dopaminergic it is agonist and antagonist.
So you SSRIs are inhibitors. Say it is an agonist. How does it act? You say presynaptic. Like a, you should know most of your exercise there. They inhibit the it actually acts on, as you said, presynaptic. Study that. And what does it do? Yes, actually, they presynaptically act for that. All of you presented well. You see, when you will go on internet, you will find a number of information, articles also you can find. Okay, I would suggest that you stick to textbooks for your references and guidelines, right? Because there are many when research is going on, then there is a lot of things that are in hypothesis. Okay, so we are also doing research. We are also doing hypothesis. You will find number of articles where there is hypothesis. This may be the reason. Okay? It is not yet when it is tested and retested and number of studies find the same findings. Then it is filtered into the cases that the evidence is strong, so that it is built up into the treatment guidelines or it comes in the textbook. Okay, so when you go online, you find number of research articles somewhere on one person who studies and finds that say this drug is not effective. And you can say that in number of research, some medicines they were earlier on disregarded. Okay, so amisulpride which you are using, sulpride which is the parent molecule. So studies found that they caused sudden death. It was withdrawn. Okay, Earlier on, it was found that butypine can cause colored vision cataract. Later on, with research, it was found it is not that common. So, if you find that study article, it will say that butypine causes cataract. So you can build in your presentation that it is causing cataract. So you need to be aware of these. When you are doing online study, you find a research article. So that research article does not give quoted research articles from any of study. That's good. But you have to, then that is what PG is about. That you have to analyze that article and see whatever evidence that is in the article, it is in terms of predictive, like it is concrete, it can be dependent upon how many patients is studied on when they do with that conclusion. Okay. So for concrete information, it is better, is at your stage to stick to textbooks and guidelines where they have, these guidelines and textbooks are built by consulting a lot of articles in their paper. Right? If you quote one article and you say that this is there may be some other articles or research which counter to this. Right? Okay. So some research may have found they may have studied one that Bupropion is not effective as effective. So, head-to-head comparison. But that does not make it ineffective. Okay. Sarthak, Maya.